Thanks everyone for joining us today. I'm Angela Jones from the Monash Partners team, and it's my great pleasure to welcome you to our webinar this afternoon. Our topic is virtual healthcare. How can evidence help us to deliver virtual and primary and community care? I'm delighted to be joined by a great selection of speakers: Adjunct Clinical Professor Karen Price, Professor Grant Russell, Jagdeep Singh, our consumer partner, Associate Professor Peter Malliaras, and Dr. Christy Matthews. We recognise that some of you may be new to the space of Monash Partners and may not have attended our events before, so by way of a very brief recap, we're an NHMRC accredited research translation centre, a large-scale partnership of 12 health, research and teaching organisations accredited back in 2015. Collectively, our health service partners meet the health and wellbeing needs of over 3 million Australians, or about 15% of the population. We also collaborate with the other NHMRC accredited centres nationally through an alliance. I'd like to begin by acknowledging the traditional custodians of the land on which we're meeting today, and in a spirit of reconciliation, I pay my respects to elders past, present and emerging, and also extend that respect to any Aboriginal and Torres Strait Islander people joining our webinar. Wherever you are, we acknowledge and pay respects to our First Peoples. Just a little bit about Monash Partners. The purpose of Monash Partners is to connect researchers, clinicians and the community to innovate for better health for the community that we serve. It would be no surprise to many of you that our healthcare sector is incredibly siloed, and so Monash Partners provides a vital collaboration platform. A link between all of the silos within our system is one way you might like to think of us. And that picture there is of some beautifully decorated wheat silos in regional Victoria. So our role is to connect all around better health for our community. Our activities are built around our enabling themes and platforms and clinical themes. This event that we're hosting today has emanated from our primary and community health platform. We have a number of other enabling platforms, and you can see them listed there. The idea of the platforms is that they bring everybody together and support embedding research in healthcare, but importantly, we know that most of healthcare is delivered outside of hospital walls. And if we're to genuinely improve the health of our community, working closely with primary and community health is absolutely vital. Here are our speakers. In a minute, I'll be handing over to Grant Russell, who will provide a little bit of an overview of the Monash Partners platform. Grant's also a GP, so he'll provide some of those perspectives and also a little bit around the evidence for virtual healthcare. We're delighted to be joined by Karen Price, who will provide some reflections on telehealth in primary care, some of the learnings. Jagdeep Singh, our consumer partner, will provide vital perspectives on the lived experience of people using telehealth in the community. Christy Matthews will speak about a student telehealth program run out of Peninsula Health, and Peter Malliaras is going to provide some insights around physiotherapy and telehealth. It's my great pleasure now to hand over to Professor Grant Russell. Grant is a primary care clinician, practicing GP and health services researcher. He's a professor of primary care research within the Department of General Practice at Monash University, and he leads Monash Partners' primary and community health platform. Before I invite Grant to begin his presentation, we wanted to encourage today everyone a little bit of interactivity, and there's a question that should have popped up now in your screen, and we'd be interested in your thoughts around how frequently you have utilised virtual healthcare in the last 24 months. So if you could respond to the poll, that would be great. I see quite a few responses coming in there. And it looks like about half occasionally. And then the rest kind of a split grant between never or rarely and frequently. That's really interesting. Thanks so much, everyone. And Grant, over to you.
Thank you, Angela. Just checking that I've got the right screen portrayed to you.
Yes,
Yep.
it looks great.
Thank you. So thank you very much for the invitation, and it's very nice to be here today. I similarly would like to acknowledge the traditional owners of the lands on which we meet today. I wanted to tell you a little bit about the primary and community health platform that Angela's already introduced. It's a platform that's made up of representatives from community programs in the local health services. So, for example, Monash Health community is represented, and similar groups in other health services. We've got representatives from community health centres, key primary care, NGOs, and also general practice. Our priorities sort of fit and articulate with those of Monash Partners, which is about building this vision around collaboration and integration. And for those of you working in primary care, that the split between secondary and primary care has been very apparent, and it continues to be so. It certainly has been throughout my professional life. We're hoping to be able to bring some relevant evidence to inform practice and promote, like elsewhere in Monash Partners, to promote data, the use of data to inform practice. And that area of Monash Partners, those 3 million people that Angela alluded to, cover a very large geographical part of Melbourne. So it's a daunting task for Monash Partners, but can I just say that the organisation as a whole, centrally, Angela and her team have done it with grace for a number of years now. As far as the seminar series, the primary community care platform had been interested in trying to articulate and interact with the primary care and beyond community within the Southeast. And so we decided to hold a series of workshops, of which this is the first, to try and increase awareness of some of the key integration issues around the wellbeing of communities in Melbourne's east and southeast. We wanted that participants got a bit of a better understanding of key issues, and that in participating, that individuals and organisations might be able to link with those with whom they haven't been before. Our process of trying to prioritise, we wanted novelty, we wanted a bit of challenge, we wanted relevance. And so the two key areas were related to virtual healthcare, and the second one around healthcare delivery. I'm just losing some of my, how healthcare delivery in the community can be greener. So hopefully that's something you'll hear about. We also would love to hear of other topics that people might be interested in us working with. Okay, so as far as telehealth is concerned, the evidence or the data is pretty spectacular. And this is a graph from the Australian government, which shows the number of requested items for telehealth services and how they changed from virtually zero. It was actually around about 30,000 a year between May 2019 and May 2020. Anyone who was working in general practice, and I'm sure in the hospitals at that time, could well understand the reasons behind such a graph. AHPRA has, as quite understandable, started to recognise that maybe this desperate urge within the COVID pandemic maybe needs to be tailored a little bit. And they've recently recommended that telehealth isn't appropriate for all medical consultations and shouldn't be a routine substitute for in-person care. They've prioritised video as against telephone. There might be some discussion about that later today, and really advocated for telehealth being in the midst of a continuing relationship with a patient, which also involves in-person consultations. Something that's got a little bit more popular more recently is that providing telehealth care without a real-time direct consultation is something that AHPRA and other bodies have been very keen not to promote. but it's certainly become a contested area. There's been anxieties particularly from vulnerable Australians about telehealth being withdrawn or cut back. There's certainly been a clearly articulated scope for vulnerable groups, in particular First Nations people. As is everything, it seems, in our life, Woolworths is getting into it, and some of the big providers are becoming more and more interested in the potential of the business model of telehealth. There are fly-by-nighters and other opportunists. This is a news report from The Guardian which showed that there were online UK pharmacies prescribing Ozempic to people with healthy BMIs. I don't think that's happened in Australia yet, I hope. And not surprisingly, complaints to the Australian medical regulators, the medical board, around telehealth have risen by 400% in 3 years. So a couple of questions about evidence. So there's a fair bit of focus around telehealth, but what about the evidence? And we're going to hear a little bit of that later on today, but just a couple of little nuggets. First one was a systematic review of studies that compared telephone or video versus face-to-face visits in terms of effectiveness. It looked at a whole range of outcomes. They had 28 studies, 2 of those were Australian, most of them done before the pandemic. But they found that clinical outcomes were as effective as face-to-face, particularly in a couple of groups: adults with mental health conditions and those attending primary care. Patients were satisfied, but discontinuation was around about 1 in every 3 patient users. And there was certainly an advocacy for more training and more understanding of some of the special skills that might be required. Second question is a big one, and it's a big one for a health funder, which is whether it increases utilisation. And this was a study done in 23 primary care clinics in New York City during the pandemic. And so they divided their population into telehealth users and telehealth non-users. And you only needed to have had one telehealth visit to be called a telehealth user. So what they found was that nearly 2/3 of the sample had used telehealth, and they were likely to be older, female, Asian, with comorbidities. However, less likely to be Black and less likely to be uninsured. And if you were a user, those users used it for 2/3 of the visits. And overall, and this is the question around utilisation, it increased around about 1 visit per person over the course of a year. Do patients like it? Well, the newspapers seem to indicate that it did, and Polinsky's study in the Journals of General and Internal Medicine a year or so ago suggested that nearly everyone was satisfied, that 1/3 preferred telehealth to face-to-face, especially if they're uninsured. So, and again, those who liked telehealth were female and had an satisfaction with that they got telehealth, that it made sense, that they were satisfied with quality of care, and that they were satisfied with the convenience. So people who liked it, who understood it, were much more likely to be utilisers and people viewing it positively. But just before we move on, I'm going to give you a note of caution, which came from Christine Sinsky, a UK primary care academic. And she said in the records of the Mayo Clinic, the common narrative is that COVID happened, payment and policy barriers were quickly lowered, and voila, telemedicine, a technology for which adoption had been slow, one might say painfully slow over the past decade, is within a matter of months in widespread and successful use. Fait accompli. Onto this narrative, and this is something perhaps to reflect on, onto this narrative has been grafted the hopes that telemedicine will solve other persistent problems. particularly in primary care. As with any other technology, the divine is in the details. So with that, I'd like to conclude and would like to welcome Adjunct Clinical Professor Karen Price, who's as I'm sure nearly everyone will be aware, is the immediate past president of the Royal Australian College of General Practitioners. Karen's a leader in general practice and a long-term advocate for evidence-based care, having practiced as a GP for over 25 years. She's currently completing a PhD on the concept of GP peer connection and may nearly have been as common a face on the media as Brett Sutton was during 2020 and 2021. Karen led the RACGP during 2 years of the COVID pandemic. She represented the profession wonderfully in negotiating early agreements with the federal government on the access, affordability and quality of telehealth in general practice. She's going to provide some reflections on telehealth in primary care, some opportunities and some learnings. But before she starts, we've got another question for the audience. And that is, what is the best thing about virtual healthcare? The options there are time-saving, access, cost-effectiveness, convenience, privacy and confidentiality, or other. And Angela, I'll let you go through the results.
Thanks, Grant. We'll just pause for a minute and see how the results come in. So obviously convenience and access are emerging as key positive aspects of virtual care. Less so perhaps concerns about cost effectiveness and privacy and confidentiality, but I think the clear winners in that one are access and convenience, which is very interesting. Thanks, Grant. And
right.
Over to you, Karen.
Okay, thank you very much, and welcome everybody. I'm very honoured to be asked to present on telehealth, and it certainly was fun during the pandemic. I'd also like to acknowledge the traditional owners today. And I just want to make a point, and I think this leads on nicely from Grant's talk, that telephone is 100 years old, and technology for video calls is decades old. And so the innovation was recognising and enabling the need for telehealth through payment portals. And so indeed, the divine is in the detail, and should I say, the politics. So if I can just forward my slides, I can't seem to forward my slide. That's a bit strange. Is that? Oh, here we are down there. Apologies. So things that we know is that we've got to balance the possibility and the pragmatism of budgets and politicians' needs. And we know that, of course, it increased during COVID, and that low socioeconomic groups use telehealth slightly more than higher socioeconomic groups, but there's probably different cohorts and demographics in those uptakes. Telehealth services decreased as face-to-face visits returned. There was a wide uptake, including remote and rural access. There were early adopters of video telehealth, but there was a large number of those were in the same sort of people. So the problem with the GPs is that there's a nudge committee. And so we've got this compliance issue, and that was a significant concern because the government is, of course, concerned about an open bucket of money as they saw it. And this participates in some of the challenges for clinicians delivering telehealth, and there may be good and bad reasons for pursuing that sort of thing. So just sorry, having trouble with my thing. So looking in our own backyard, there are exemptions for face-to-face care. But I note recently that, for instance, sexual health and sexual and reproductive health is an exemption for needing face-to-face care within the last 12 months. And now some of the entrepreneurs are actually asking a sexual history, whether it's relevant to the presentation or not, in order to get around it. So we do have to look at our own back garden as providers. There, of course, as Grant alluded to, telehealth private companies, which need some scrutiny. And our major principle here, and I'm going to talk largely in principles today, is avoiding fragmentation, balancing the needs of access, and that includes high quality indicators, which is a high quality indicator of high functioning primary care. And cost can be another another principle underlying access. So this is a cost to government. Of course, they want it cheap, and we can argue that it's an investment, but there is always, as we know, there's no money tree. And there's also a cost to providers, of course, because we need to be adequately remunerated for time and effort, and for the risk that telehealth may propose. And patients, of course, have challenges in determining quality, and their choice is important to note for both government and providers. And we need to keep reapplying those principles as we look at things. So just a pause here. I just want to consider here that we are also emotional beings, a bit more than rational. And the underlying drivers of human experience are really important to note, that how we appear and what our underlying needs are may be quite different. So there's a big need for emotional validation in human beings, and there's a big need for esteem-related discussions also. So I just wanted to note this because I'm going to talk a little bit about the underlying drivers of human experience. And when we talk about continuity, quality, and safety, we're also talking about therapeutic alliance. And these underlying human drivers are well worth considering. So in terms of provider preference, Grant's provided some good studies there. There's also one down there just recently from 2023. And we know, I think the term I want to use today for everyone to take away is it depends, whether video versus telehealth, telephone modalities for telehealth are the best. And it really, it's a complex choice. It's tied to a whole lot of different factors, resources, preferences, timing, and when appropriate, it is obviously an adjunct to usual care. In terms of patient preference, well, again, the same principle applies. It depends. And this is another study also released this year, and I think we're going to see more and more of this, which is really good to understand where we are. Australian patients liked a blended approach. And while in general face-to-face contacts were on average preferred, virtual care was identified as attractive if it prevents significant travel, which is important for remote and rural, but also for very busy people in jobs where they can ring up their usual GP and have a telephone or telehealth virtual consultation and not have to take a whole afternoon off work. So there's a whole range of access issues there. And importantly, can be conducted with their own GP. And finally, cost was also a significant driver of choice. And if telehealth services can be delivered with minimum out-of-pocket, that was also a decision that patients took. And of course, this is a great little picture of humans. And on the left-hand side of your screen, there is the robotic self-order cubicles at McDonald's. And you can see that patients are choosing, or not patients, consumers are choosing the checkout person and human contact. So again, a very interesting little contrast. So I think the future is really exciting here for healthcare providers, and I would like the audience and everybody to consider the value of that therapeutic alliance and continuity and access and cost going forward, but insist that we have a frame of humanism over very highly process-driven solutions. And in other words, we need to prize our human connections in face-to-face care, always, of course, with caveat. And we need to advise policymakers to be circumspect regarding some of the advertorials that I saw coming from technology-based for-profit companies. So they're the challenges that we have in this new so-called innovation area. And humanism in healthcare and technology, as I said, is a worthy lens. And now I'm going to sort of finish off here and talk a little bit about some of the process. So high-level principles of primary care need to be enacted through telehealth. We need to consider, of course, absolutely patients' preferences, but also providers' preferences. And there's a whole complexity in just talking about those particular presentations. So we're going to talk about the process. That's a sort of, I think, a bit of a look of a cyborg. I'm not quite sure where we're going in future, but it's going to be interesting. This is a study from the Lancet that through Trish Greenhall's unit at Oxford, talking about safety errors in telehealth. And this is a roadmap, and there's a particular table in this article, which I think is really, really helpful for policy and providers, and maybe for patients too going forward. We actually do need process. I'm not an anti-process person. I just don't want it to be the whole and wholest bolus of how we deliver healthcare. as long as we view process in a complexity framework, which is what we're sitting in healthcare, and we never forget that it depends phrase, and that we're always capable of holding the two conflicting ideas depending upon the context of where we are. So table 2 from this article talks about reducing safety incidents in virtual or remote, as they call it, primary care. And so they've talked about, just as a useful kind of framing, the clinical conditions which an in-person assessment is often required. And I guess for the list of that and for the clinicians online, this is pretty obvious, but it may be useful when we're talking about a system approach and we've got people who may be manning the phones, who may be utilising the triage into who goes into telehealth of various modalities. And there are clinical trajectories for which an in-person assessment is often required, and that is that conditions that aren't resolving, as we know, and as always, if you attended, like me, the Royal Children's Hospital as a resident, escalating parental concern, still a high red flag in general practice. And of course, acute conditions overlying chronic and pre-existing complex illness, including mental health. And patient-level features that make remote assessment more difficult. And this is where the risk frameworks come in for people providing telehealth. Extremes of age, of course, care home residents, obviously people who don't speak English, relevant impairment like deafness, autism that might complicate communication issues, and low health literacy, which is a big one, I think. And key features of effective safety netting, I think this is really important in even face-to-face consultations. I usually write out a management plan so the patient knows what the next steps are. And I think in telephone and video consultations, this is extremely important so that patients know where to go should there be a concern regarding their consultation or the condition that they're presenting with. And in terms of organisation and system level measures, this is really important for people, again, for clinics and for institutions who are providing telehealth. Obviously, adequate staffing and appropriate care, which sounds simple, but we know it's not. Optimising those triage pathways and workflows for the virtual and knowing how to manage that at the front desk. There may be someone who's not clinical actually taking some of these calls and determining who goes where. Protocol for at times of extreme stress, such as staff absence or very high demand. And in economics, there is a term called redundancy in systems, and that's a really important concept so that people aren't hugely stretched when we're under the pump, because that's when often a lot of handovers and triage, when you're under the pump, is when things can go missing, Swiss cheese model of errors. And making sure there's some redundancy in that system, some elasticity in staffing, some elasticity in protocols, so that we can make sure we keep people safe. And finally, from a patient's point of view, and this is where health literacy is really important, making sure perhaps the patient or the clinic or the organisation has a list of or an instruction list for patients so they can understand what might be suitable for telehealth or what might not be. And making sure they insist on the clinician telling them exactly what has gone on and whether there's a plan to go forward should things change, and making sure they voice very adequately and clearly their concerns and don't do that very much unfortunate approach of trying to not cause a problem to the doctor or clinician online. So finally, I'm going to finish with generalism is expertise in complexity. It depends is my go-to phrase. Policy doesn't always like complex solutions, and we are dealing with policy and politics here because we're dealing with budgets. We have to articulate our professions intelligently, quantitative as well as qualitative principles, and we must always ensure that context is king and patient-centred design principles are central. And just to emphasise that you, the GPs who I'm talking to, are experts, and we need to describe that it depends phrase in the way policy and process people can understand. And we must remember that not every innovation is possible, and the principle of health systems being integrated, the Shangri-La grant, and avoiding those mercantile motives, which is opportunism in some of these new developments for accessing healthcare. So policy doesn't like complex solutions, but we must be able, therefore, to articulate this research in best practice and having that integrated complexity for our profession. So it is all about bringing people and health care together. And if technology can enable that safely and appropriately, then I think we will go forward. I think it's a very strong platform, and I'm looking forward to seeing where it can go. But we need to make sure we've got the research, as you've seen today, to be able to tell policy people what is worthwhile, what is perhaps not, perhaps a bit more opportunistic, and maybe not be the basis of good healthcare. So thanks, everybody. I think we've got some interesting ethical challenges going forward.
Aaron, thank you so much for your leadership perspectives and insights. Terrific to hear about. It's my great, and we'll look forward to hearing from you more in the panel discussion in a little while as well. It's now my great pleasure to introduce Jagdeep Singh. Jagdeep is our consumer partner for this event today. He brings a lived experience and perspective of telehealth and virtual care. Jagdeep is a member of the Multicultural Community Engagement Network, a partnership between Enliven Victoria, City of Casey, Cardinia Shire and City of Greater Dandenong. Jagdeep has experience of working with the Sikh community in the southeast. Compassionate Hands has been a multicultural community engagement network member since 2020. During the pandemic, he provided first-hand support to members of his community in utilising virtual healthcare. And today he'll provide some perspectives of that experience. And over to Grant, who's going to engage with Jagdeep. Thanks, Grant. Thanks, Jagdeep.
Thank you, Angela. Jagdeep, wonderful that you could join us today. Really very much appreciated. The way we're going to do this is I'm going to run through some questions, and then Jagdeep will be answering those questions, and he'll be joining our panel once we've finished the speakers. So Jagdeep, I wonder if you could unmute, please. Yeah. Thank you. And my first question is, I was really interested in that organisation Compassionate Hands, but I wondered if you could tell the group here today a little about your work in the community.
Yeah, good afternoon, everyone. Thanks for calling me and inviting me for this. Well, I'm the president of a group called Compassionate Hands. There are 130 members from India, Pakistan, Afghanistan, and Nepal. I arrange English and computer classes for them. I take them out on excursion tours to gardens, beaches, ferry rides, trips to Puffing Billy. I invite guest speakers who come and deliver lectures on health and aging problems. I keep them busy in outdoor activities like singing, dancing, and games. Above all, we all do environment cleaning in parks, roadside, and stations.
That's fantastic. I wonder if you could tell us how this community experienced telehealth particularly during the pandemic and then beyond.
Yeah, during pandemic, during COVID-19, it was very crucial time for everyone, as everyone was scared of meeting and seeing anyone and avoiding meetings and gatherings. But obviously, seeing GPS for vulnerable problems was necessary here. There were some issues faced by the community, as during this time, some GPs were only offering telehealth appointments. This caused a problem for my community due to lack of technology, infrastructure, as they were not in position to operate the gadgets like smartphones and laptops. Second problem was language barrier. This was the foremost problem for seniors who have migrated from Asian countries. If they couldn't see a GP who spoke their own language, they could not talk or narrate their health problems in English. And they always looked forward for GPs with whom they can talk in their own language. Some members of community who were religious and they didn't want to share their problems with unknown GPs, they couldn't get appointments with their own GP.
So problems with technology and problems with language.
Language was a barrier was there.
And can you tell us a bit about the impact of those barriers?
Yes, the worst disadvantage was the lack of physical interaction and examination, as telehealth didn't allow patients and doctors to meet so that the patient could physically show the GP where the problem was. Some community members avoided seeking help for their medical conditions due to this. A background noise was also an issue, as some community members who were low listening reported that there was audio background noise when speaking with their GP. For example, telephone line was not clear and network was down, so they faced such kind of little problems at the time.
Thank you. And so the really challenging time, and I wondered if you could tell us how your work as a community leader was able to help overcome some of these barriers.
Yeah, well, I supported my community by setting up telehealth appointments and was beside the community members to support them through telehealth appointments. I also encourage my community members to seek help if they are not feeling well. And I used to communicate and help them in booking the appointments.
Okay, that's wonderful. So after a few years into this experience now, I wondered if you've found or identified any benefits from telehealth.
Yeah, definitely. There were some benefits of telehealth, which included increased access to healthcare and reduced risk of COVID transmission. And for those members who lived in rural and remote areas, also had increased access to the healthcare. There were reduced time and costs associated with the traveling to appointments, and community members found it more convenient with the reduced waiting times as well.
So it sounds like the community were quite satisfied once some of those areas got over.
Yeah, they were happy, and they were so they did all they could get sitting at home, but virtually going to the GPs and the hospitals or to the medical centers.
Jagdeep, thank you very much for that.
All right.
We will look forward to hearing you expand on that, hopefully, when the panel starts. And I'm just going to hand back now to Angela and to move things on. Thanks,
Grant. Thanks, everyone.
Thank you.
Thanks, Grant. Thanks, Jagdeep. Everyone, our next speaker today is Dr. Christy Matthews. Christy is a senior lecturer and coordinator of the Student Telehealth Program at the School of Primary and Allied Health, and a senior research fellow with the Monash Centre for Scholarship in Health Education, both at Monash University. Christy is a radiation therapist by background, and her research interests are health professional student preparedness to practice and health professions workforce redesign. Today, Christy will be speaking to us about an evaluation of a Monash University Peninsula Allied Health student-run telehealth clinic. Before we go to Christy's presentation, we have another question for you, and it is, to what extent do you think healthcare practitioner graduates are well equipped to deliver virtual healthcare? We look forward to seeing your responses to that question. So it looks like it's fairly strongly a no or an unsure, but not a strong response rate to yes. So interesting. Thanks so much, everyone. Over to you, Christy.
Thanks so much, Angela, and really interesting to hear your results, and hopefully we can allay some of those concerns during the presentation today. I would also like to add my acknowledgement of country and acknowledge the traditional custodians of the lands on which we are meeting virtually today. So today I'm going to be discussing the outcome of our student telehealth program that we commenced in August 2020 in the School of Primary and Allied Healthcare at Monash University. Sorry, my arrows aren't working either. Oh, here we go. So the aims of our program when we commenced in 2020 was to provide a person-centred health coaching outreach opportunity for people in the community with the aim to improve their health and well-being. But alongside that was also to provide learning opportunities for our health professional students, so primarily allied health at this stage, but hopefully looking to evolve into different professional groups to engage in person-centred care and wellbeing interactions via telehealth. And our motivations for doing so, obviously, as we've heard today, telehealth is growing. So we do need to enhance the graduate capability in this area. So really interesting to hear that the majority of the audience don't think graduates have capability in this space. So we're looking to close the gap there. We also wanted to really engage our students in person-centered and shared decision-making experiences, so to make them better clinicians in the future. And also just to note, Monash University strategic plan, one of the key pillars is around thriving communities. So we really did want to create some sort of community engagement opportunity where we could add value to people in the community. So how the program works, so starting over here on the left, it sits within a research framework. So our participant recruitment is through the general community, primarily through social media. And before students and community members start working together, the students have a standardised training and assessment program where they learn about telehealth, they learn about health coaching strategies, motivational interviewing, behavioural change techniques, and also professionalism, so they can understand clearly what their role is within this program. In the middle then, the students and the participants are linked together, so it's a one-to-one relationship, although students do work in pairs with an observer student to support peer discussion and peer learning. And so together, the participant and the student work through health screening to identify what the primary health and wellbeing concerns of the person are at this time, the priority of those particular needs, and what they might have tried in the past to address those needs. And then together, the participant and the student will determine evidence-based strategies and goals for improved health and wellbeing. And then depending on the nature of those goals, a few weeks later, they will have a goal review. And then from there, it's really up to the participant and the student to determine subsequent conversations around different issues or goal modification. And as part of the research component, we also gather information on the participant experience of the program and also the student experience of the program. And overseeing this entire process, we have a research infrastructure underpinning all of these measures so that we can determine outcomes, and also we have a governance framework within the ethics process. We've created a custom-built database which operates similarly to a hospital record system, where participant records the information that the students are collecting on the participants resides in a secure database. And students have distant or long-arm supervision from a health practitioner supervisor from within their professional field. So in terms of what we've achieved so far, the program is ongoing, but this is a snapshot of the data from August 2020 when we commenced until January 2023. We had 613 community members from all over Australia participate in this program. So as you can see, the split of gender is primarily female, primarily in that middle band, middle age group, I guess, from 46 to 75. Location Australia-wide, although most on the eastern seaboard. The split of disciplines that have worked with the participants. So most participants have engaged with occupational therapy students. This is more a reflection of clinical placement opportunities and duration of time, as opposed to aligning their particular problems or needs with a particular discipline. And we've had 237 students through the program. So that's just over a 2-year period. So in terms of the outcomes, so looking at some of the data, so just on 10% of our participants, those 600 plus people, choose to work on more than one problem with their student. And just on the left-hand side there is a snapshot of the World Health Organization Quality of Life brief domain. So the student and the participant working together will self-determine how those issues are described within the system. So it's in the participants' words what their particular health and wellbeing needs are. So this is post hoc analysis of those particular issues, where I've categorised the issues according to those domains. So primarily, just this bottom point here, majority of issues that people are recording are around physical health. So things around pain, things around trying to enhance physical fitness, physical well-being. Sleep is something that comes across frequently, and fatigue, but also psychological health. So we have seen quite a degree of stress, anxiety, and mental health associated issues that our community participants are working on with our students. So in terms of outcomes, so looking at health-related quality of life with the EQ5D5L scale. So we collect the data from the EQ5D both as a participant is starting the program within the screening tool and at a post-program evaluation. So this is a snapshot of some of the items on the EQ5D scale. So of 339 participants who have participated in that final evaluation, we've seen a mean improvement, which is statistically significant, of 0.07. So that's the equivalent of jumping up one of those scales within those ranges. So from moderate problems to a slight problem, for example. It is a small effect size, but we are seeing an improvement in the or self-reported improvement in the participants that engage in this program. So that's pretty awesome. Our students and our community participants are working together for improved health and wellbeing. So some of the qualitative feedback from this program as well, as you can see on the screen there. So this is participant feedback. So it's been one of the most positive things I've done in a long time, some of the feedback. As well as the self-determination that the students can help engender in the participant around giving them confidence that they're on the right track around improving their health and wellbeing. And similarly with our students, the students are finding that engagement in the program is a positive strategy around improving their communication skills, clinical reasoning, self-management. So students are largely independent in their management within this program, being a distant supervision, but also in the way that they learn skills to engage with the community members as individuals, as people, and really practice that person-centered care. So aiming on empowering the person to make health decisions for themselves, and that the student is acting as a coach within that relationship, as opposed to enforcing particular directions for the participants. So just as a summary, the program has provided a really positive health coaching outreach to people in the community. It's also enabled the students to develop a range of relevant capabilities. So not only familiarity with telehealth and how telehealth can work, but also, as I said, they're practicing semi-autonomous decision-making. They have to manage their own time, and they have to also work within their teams, and they're learning those person-centered care and shared decision-making skills. So in terms of the future, this program is ongoing. We're looking to engage other disciplines. So in 2024, we're hoping to have podiatry and dietetics students in the program. And we're also engaging with infrastructure. So we have infrastructure in place for 2024 where we can support more in-person student learning within this program. We've got telehealth pods, booths actually at a facility. So students will get the best of both worlds in terms of their learning and engaging with telehealth and engaging in that peer support and with their supervisors. So I'll leave it there. Thanks so much for listening.
Christy, thank you so much for your insights and your innovative program, Preparing Health Practitioners. Terrific to hear from you. It's now my great pleasure, everyone, to introduce our next speaker, Associate Professor Peter Malliaras. Peter is a physiotherapist and researcher at Monash University and is involved in multiple research projects in the area of multiple tendinopathy, both in Australia and internationally. His research focuses on understanding pain and neuromuscular impairments and clinical trials testing of various interventions, and he maintains a very strong clinical focus. Today, Peter's talk will be focusing on the use of telehealth for patients experiencing musculoskeletal pain. And before I hand over to Peter, we had one final polling question for you all online. And this one is around an opportunity to tell us about the biggest barriers to virtual care. And that question should pop up in just one moment, and then we'll go to Peter. And there it is. So interestingly, limitations of physical assessment, not surprisingly, being a barrier to using virtual healthcare, that inability to examine patients. And then some of the other challenges, technical issues, which I think Jagdeep alluded to with some of the people in his community who didn't have access to smartphones. And then also communication and language issues, picking up on some of the points that Karen made about us being emotive and social human beings and those kinds of needs. So thanks, everyone. That's really interesting. Peter, over to you to hear about your work.
Fantastic. Thank you very, very much, Angela. Thank you for the introduction. Thank you for the opportunity to speak here today. So I will be sharing some experiences with telehealth, particularly with a couple of studies that we have undertaken, probably over the last 5 or 6 years. And that was a really good segue, actually, that quiz, because I will be talking about some of the barriers that we've identified with some of the work that we've done as well. So, yes, I'll talk about, so the sort of main areas that we've been focused on is telehealth interventions for shoulder pain, as well as, and that is a full telehealth model where people only receive telehealth. And then there's also a hybrid telehealth model where we are treating people with Achilles tendinopathy. They also have in-person care, but they are able to have telehealth care that supplements that as well. So I'll try and sort of hone in on some of the experiences and the barriers and some of the lessons that we've had, trying to keep it a little bit more clinical. So in terms of the pros of telehealth, I think we're all really well aware that there are huge advantages with telehealth care. Some of these have been mentioned already. Looking at access for certain populations, particularly people in various geographical areas, disability. There's a huge convenience element to telehealth as well. There's potential to improve adherence, and this is one of the things that we're really interested in. One of the problems with musculoskeletal pain physiotherapy is that often we don't get the level of adherence that we're after to get people the outcomes that we need. So that's one of the sort of motivations for some of the telehealth work that we've done. Reducing treatment delays, this is also really, really relevant, particularly during COVID and post-COVID, where there are long waiting lists for musculoskeletal care in various settings. So all these are really important advantages. There are disadvantages that we also need to consider with telehealth care. So, and some of these were just highlighted now with the quiz, but we know that there is a perception that quality may not be as high as face-to-face care. There's also issues with technology. Developing rapport is another barrier that comes up. And there's also patchy insurance cover, which has also been mentioned today. So our sort of move into telehealth, as I say, started about 5 or 6 years ago, we had a look at the evidence, and there seemed to be at that time, and this was pre-COVID, developing evidence that we can use telehealth for MSK conditions, but no specific evidence in shoulder pain. So we know that we can diagnose people with shoulder pain pretty reliably via telehealth, and it's pretty comparable to what we do face to face. So we thought, let's look at trying to deliver some care for people with shoulder pain via telehealth. So this started pre-COVID, which was really fortunate because we were sort of ready to go with an intervention when COVID started, and have been able to continue that work during COVID. So we and the sort of underlying I guess, goal of the intervention was to improve the quality of care. So we know that for shoulder pain, the quality of care is quite variable in primary care. So a lot of people don't receive care that is recommended. So our thinking was that we can really scale telehealth, and we can deliver care that is recommended to lots of people regardless of their geographical location. So we applied for funding, and we were successful with pilot funding from Arthritis Australia, and have subsequently completed that pilot. That's been published, and we then secured funding for a full-scale trial, for which we've recruited 346 people. They're still undergoing sort of follow-up. So I'll talk mainly about the pilot, which we do have some data for. But effectively, it was a 3-arm intervention. So we compared an education leaflet, which was an active control. We compared that to education, more comprehensive education and exercise that was delivered online only. So that was an online intervention. And then in our 3rd arm, we also added a telehealth, additional telehealth care. So this was meant to be a way of coaching people, of supporting them with the online intervention. So supporting them through what we were delivering in our online intervention. So we developed the intervention with stakeholder input. So we spoke to patients, we spoke to clinicians. We developed an intervention based on their input, and that's what we tested in our pilot. Then we undertook some qualitative work to further refine the intervention, and we're now testing that intervention in the follow-up full-scale trial. So this is the findings from our pilot. So our pilot, and again, we haven't done any statistical analyses on these because it is a pilot. We had 12 people per group, and what we found is that there was some signals of benefit if we're adding certainly telehealth. This is a pain and function outcome for shoulder pain. The clinically important, the minimally clinically important difference is 8 points on the scale. So we found that certainly adding an internet intervention, even to usual care, there was benefit, just based on the numbers without doing any statistical analysis. And there was also further benefit when adding telehealth. So we thought that was a good indication of potential benefit to then go on and apply for funding for the full-scale trial, which, as I say, we're sort of working through now. In terms of some tips and some things that we've sort of implemented as we've gone through, one of the key things that we've learned is that people really need to be ready for telehealth before the telehealth session. So it's really, really important to screen people for readiness to engage with telehealth. And this includes readiness to engage with some of the technology and software that they're using. But also whether they have strong ideas about the treatment that they need. One of the one of the key barriers is patients' perception that's especially for musculoskeletal physiotherapy and for physiotherapy in general, that hands-on treatment is essential and hands-on treatment is going to be part of what they're going to be receiving. So looking at trying to understand where people are coming from before that telehealth session, trying to troubleshoot some of those technology-related barriers that are really common. The other thing that we've found and we've implemented with our trial work is making sure that we're screening all of the, first of all, diagnosis. So we screen people in a two-stage process. We first of all ask them to complete a questionnaire with sort of key diagnostic questions. We then move on to a telehealth, a brief telehealth Zoom screen where we can further screen them and make sure that they're appropriate. And that's probably something you wouldn't necessarily do clinically, the second step of the telehealth screen. But the initial step of online screening, I think, is really important, just to flag anything, anything major, red flags, anything that may not be appropriate for telehealth care. The other thing that we do is we spend some time before the session making sure that they have adequate instructions. So one of the things that has come through even today is the lack of training and education about how to implement telehealth. So one of the things that has been helpful is to provide information about just basic things like the setup, how they're going to be, the technology, where it's going to be placed, what positions they're going to be in. So all these things that will help them set up before they actually engage with the first session. And looking at the actual then session and when we're with people, one of the things that we have learned is to really enable lots of time. It's different to face-to-face care, as we know, and one of the things that helps with a telehealth medium is to make sure that there's lots of time to reassure people, reassurance and reflection. So after the history, pausing, making sure that people are on board, making sure they've understood everything. And I think that is really important for developing rapport, because it is so much more challenging to develop rapport over telehealth, and enabling time. There's nothing worse than a really rushed telehealth consult. So enabling time to reflect, to pause, to make sure that people are on board after the history, after the physical examination, and then again at the end. So the other area that we have done some work in is looking at a hybrid model for Achilles tendinopathy. So with the hybrid model, what we looked at here was delivering exercise, but also supplementing that delivery of exercise with telehealth sessions. So we had a weekly telehealth session, and that supplemented that initial delivery of education that was face-to-face, delivery of exercise that was face-to-face. So the key the key reason to do this was to try and improve adherence. We know adherence for these conditions to exercise is generally not very good. So we were able to measure adherence in a really robust way, because we asked them every week, we asked them about how much exercise they did, and they were able to report to us directly. So not a little bit disappointingly, the adherence wasn't as high as what we thought it might be, but we did measure it in a way where we were confident that what they were reporting was actually what they had done, because we were able to log into their to Zoom with them every week in their gym environment where they were doing the exercise, and actually watch them doing exercise. And that had some real benefits, and that will come across with some of the qualitative work that we have, that I'll talk about now. So looking at sort of general experiences and I guess some of the lessons. And we've done a number of studies. We've done a couple of mixed method surveys among allied health, but also allied health clinicians, but also patients. And then we've done our qualitative work from our trials. So this is just a summary of some of that work. What is coming across is that there's a real accountability and a real benefit for adherence when people are engaging in telehealth, and that could be that we are able to view them in their own environment, we're able to correct what they're doing, we're able to provide the reassurance at sort of timely moments during their rehab. So that is appreciated, and it definitely is a strong factor that comes across when we speak to people about what we've done. The other key one, and this has been mentioned already, is physical contact. I think from a physiotherapy point of view, we are, I guess, viewed within our profession, but also outside of our profession by the public as people that do deliver hands-on care, partly. So it's the lack of ability to diagnose, but also manage with hands-on care that I think is a real, perceived as a real barrier, both by patients, but also really strongly by allied health clinicians. So that's something that clinicians really don't like about telehealth care, it seems. And then harder to develop a therapeutic relationship. And I think this sort of flows on from this, lack of physical contact and the perception that that is so important in developing a therapeutic relationship with people. The lack of that is perceived as a real issue, particularly by a physiotherapist, so more so by the physiotherapist than the clinicians for that one. So in terms of key take-homes and learnings, I think what we probably do need now is appropriate training and resources. So we know there's been a real explosion of telehealth services during COVID, and we've all sort of been learning as we go. But trying to create better support for clinicians, I think, is really, really important. We've got a grant through PACCOSH a couple of years ago now to create a musculoskeletal telehealth toolkit, which is now complete. So have a look at that, Google that, it's on the Trek website. But that goes some way, but we do need more in that area. I think we need to address perceptions that it's lower value than face-to-face care. We know that with the evidence we have at the moment, and that is emerging and growing, that we can deliver good care. And I think it's an opportunity to reflect on what we do and what we offer as physiotherapists, because the core guideline recommended treatments like education, exercise, we definitely can deliver via telehealth. So it gives us an opportunity to deliver things that maybe are even higher value than some of the things we can do with face-to-face care, if we can overcome some of the barriers to telehealth. Thank you very much.
Peter, thank you so much for those insights. Great to hear about the pros and cons, but what can be achieved in a telehealth context. I'm going to invite all of our presenters to turn their cameras on, and I'm going to hand over now to Grant to facilitate the panel discussion. Thanks, Grant.
Thank you, Angela. We'll just wait maybe till Peter's screen just goes off.
Oh, yep.
And check that everyone's got their cameras on. Wonderful. All right. So Angela and I are going to be tag teaming this, and Angela's going to be particularly keeping a bit of an eye on the questions in the chat. So for those who are participating, do feel free to share with us questions, reflections, thoughts that you may have. I've got so many questions actually, and but I wanted to start off with really a question about the future, and what is the future of this modality? Let's restrict it to clinical consultations in healthcare. What do we have to be cautious about? And I'd like to ask all of the participants, but maybe if possible, starting with Jagdeep, what would worry you about? Do you have concerns about the future with telehealth, and how do you see it panning out?
The language barrier for the communities coming from Asian countries is the biggest drawback. And sometimes their children are not at home and they need an emergency get problem, and they need to talk. They need help from the GP. They can't get the GP. Those who are good at their language. That's the biggest problem we can face.
Thank you. Yeah, and I guess it means that we've got to remember that the telephone interpreter service can be used with telehealth, but there are restrictions with that. I'm pretty sure that many allied health disciplines don't have access to it. Christy, how do you see the future, and what would you feel that we need to be cautious about?
Look, we've had such positive outcomes from our program from a health coaching perspective. So I think speaking from that lens as opposed to GP primary care. But in terms of cautions or perhaps more considerations, one thing, echoing Peter's presentation ending there, one thing we've been really challenged with is around perceptions. So trying to roll this program out more thoroughly across the disciplines. There's hesitancy from some of the students around seeing telehealth as a valid part of their future capabilities as health practitioners, but also some of their academics not willing to support telehealth as part of the placement opportunity, the fieldwork opportunities. So that's been a challenge, but also some academics also express concerns around regulatory requirements. So whether there are requirements from AHPRA or other bodies around number of clinical placement hours and what clinical activities need to look like, telehealth is not recognised as part of that. So that's been a challenge with some of the disciplines, physiotherapy in particular, as Peter alluded to, that perception around things needing to be hands-on. That's been it's been a particular challenge.
Thank you. Mentioning Peter's really interesting work. What do you feel that a physiotherapist would or could be doing with respect to telehealth in, let's say, 5 years' time?
Yeah, it's a good question, Grant. I think the risk is that we go back to what we were doing before COVID, and that is not very much at all. So I think we do need to find out. There's probably a safety element. So the safety element is, what can we treat safely and effectively, and that's where we need to do a whole bunch of different work, not only efficacy studies, but also finding out, which populations, and we've talked about, called populations and other people that maybe might not, maybe will struggle a little bit more with telehealth. So we need to find out when it's going to be appropriate. We also then need to really overcome these barriers around people perceiving that it is second best treatment. So I think there is a lot of work to do to try and as Christy was saying, it's the perception. Most people will gravitate towards face-to-face care if they can, if that is an option. So it's really when it's not an option that it's used now. And that's what happened in COVID. It wasn't an option. face-to-face. So everyone used it, and we learned a lot. But now we think we want to go back. So I think it's trying to find the value and highlight that value that it has, even in the circumstances we're in now, where we can do face-to-face, and really supporting clinicians to use it properly and to use it with confidence. So yeah, there's a few obstacles, but I think there's so much work in this space now that in 5 years' time we'll definitely be using it a lot more than what we were pre-COVID.
Yeah, so it's a safe answer, but that's a good one. Thank you, Peter. Karen, you've had the ear of government. Thinking about the future, what do you think we need to be careful about?
Well, when they trimmed the telephone telehealth down, I got a lot of pushback from government because I was still advocating for it, because I knew in my experience and from the data that particularly mental health consultations for vulnerable groups were very much enabled through the initiatives, and removing long telephone access was a problem. So we have to think about the principles of healthcare, and that is, as everyone's described, access, which includes all of the issues we've discussed, the cost of it to both providers and to patients. And we really have to interrogate what quality means. And I think that's such an important part of advocating for new modalities of delivering care, and developing more risk frameworks, such as I highlighted through that article from the Lancet. And I think, we can never lose sight of the inverse care law, which is there's so many different cohorts in that: rural and remote, Indigenous populations, people who don't have English as their first language, those suffering some other conditions that make it hard to access. We've got to make it a way of improving access to care for them. And so never losing sight of the therapeutic alliance. I think it has to be embedded in a usual care framework in face-to-face means as much as possible. That may not always be possible. And we've got to put on our risk framework the commercial determinants of health. We really have to push back very strongly as mutual healthcare clinicians interested in quality, that opportunism may present a good, simple, and very wrong solution. And it's hard when you've got a population that may struggle with that health literacy on the quality conversation that we need to have. So again, I think it's a really important way to progress. Who knows, we might end up with holograms and maybe even enabling more asynchronous means, although they're very challenging. I think we're all learning as we go about how we communicate better with each other. And like I said, connecting up healthcare providers to patients for good quality healthcare has got to be a plus. So how we enable that with our frameworks is part of our research going forward, I would expect.
Yeah, thank you. Angela, anything you wanted to ask here?
Perhaps just to pick up a couple of comments in the chat, Grant. I think someone's commented that in their experience, and I think for most of us, that GP appointments have usually been telephone and not video enabled. And another comment about clinicians not considering telehealth as a modality when triaging, and that being a potential barrier. And then there was another question here, perhaps to you, Peter, about some interest in the rates of internet and telehealth intervention during the study. If you wanted to pick up on that one for a moment.
Sorry, I was on mute.
That's okay. You used rates for internet and telehealth as an intervention during your study.
Okay, it's a good question. That's a really good question, because one of probably the biggest drawbacks to purely internet care is that it's not really, the uptake is not very good. So, and that was also the motivation to couple it with telehealth, to provide the coaching, to provide the support for people. The internet care was people were far less engaged than the telehealth arm. So I think the outcomes are still much better than the active control in our pilot, but I think about 30 to 40% from memory of people just did not engage at all. So they either entered once and never again, or entered for a very small amount of time, or not at all. So once they found out they were randomized that arm, they did nothing, and that sort of goes back to finding out the reasons why, and trying to target care to people, because internet care can work, and it's obviously very, very cost effective, because it's completely there's no requirement for people to deliver it, but it's not going to work for everyone. And certainly we've got a grant that is being assessed at the moment where we're actually trying to we're proposed, grant is part of this one as well, where we're proposed to translate the intervention to different called languages that are commonly spoken, but we still need to test how well that's going to work.
Thank you.
Follow-up question to that. Again, the question is, why do you think the mean change is still quite an improvement despite the low access?
I think people that engaged did really well, and it was probably because they had a high health literacy and they were able to read through and engage and do things and still had a good outcome. But it goes back to the points that have been made a few times today, and that is, what populations are we targeting, and are we going to open up health inequalities because we're only targeting certain populations with these interventions? So I think it's a really important point for us to consider.
There's certainly a long history of technological and other interventions just simply increasing the gap between the haves and the have-nots. I think it's clearly something we've got to be concerned about. I had a question for Christy, and it's about, I was really interested, and I think I must have missed it, but what was the offering advertised to the community with respect to this, to the student clinic? So what was being sold, if you like?
Yeah, good question, because I didn't cover that in the presentation. You didn't miss anything. Part of our ethics approval, I guess, is that we're not delivering a health intervention. Like, that's not the intention of the program. The focus is student learning. So we advertise it as volunteers needed, come support the health professionals of the future. So we end up with a very broad range of participants, some who feel they're very healthy in their lives and don't feel the need for any support, through to those who have multiple comorbidities seeking multiple supports. I've got a couple of fellows who have been on the program for nearly 2 years working with successive students, because they really appreciate the connection and the safe connection. I guess it's a student. That whole power dynamic is different than when you're working with a health practitioner. You're not sitting in a GP's waiting room and you've got your 15-minute slot and you feel rushed out the door. So some people really embrace that opportunity to work with the students, where others, their motivation is to support student learning. And we're getting a lot of repeat attendees as well now, which I think is a really, really good sign. So they'll get through the program, they'll finish up and they'll say, oh yeah, I'll give it another go with another student. So it's been overall a very positive experience.
Could it be that part of the benefits could be that of connection in a fragmented and isolated world?
Absolutely, particularly during COVID. Absolutely. There was a lot of issues expressed by the participants around social isolation. And so just even the opportunity to connect with our students. We've also had, anecdotally, of course, but really positive feedback from remote communities. So people who are geographically isolated don't have access to the local OT to help support their difficulties getting their socks and shoes on. And one of our OT students was able to work with a fellow who lived in a remote community, Central Australia, to use items from his shed to create an assistive device to help put his socks and shoes on in the morning. And he actually sent photos of the end product, and he was absolutely thrilled, not only from the positive impact on his day-to-day living, but also the creative outlet in creating something. So that's where our students are able to take their time to build that relationship with people and really hone in on what the needs of that individual is.
Great, thank you.
Thanks.
I'm just going to pick up on that point of connection. I know a little bit about Karen's PhD thesis, and that connection is a very strong theme of it. And I just wondered if you have any reflections about this component of telehealth as a component of normal care and connection, and how there might be some common ground between the two.
Yeah, well, I wouldn't want to give you my 80,000 word thesis in a few minutes, Grant.
Oh, you gave me that 2 weeks ago.
So thank you. But look, I guess my thesis is about connections between GP, but it also looks at relationships, and I'm coming very much from a humanistic frame, and how having experience as the president of the college and dealing in policy, dealing in lots of subcommittees that report to government, very much the evidence is quantitative, big data sets, and we miss the patient's voice in that. We miss that even the provider's voice, which is part of the quadruple aim, making sure the physician's experience of delivering healthcare is good and the patient's experience of receiving healthcare is good. And perhaps part of that, it's not the subject of my thesis, but perhaps the subject of that is part of those humanistic qualities that are very much missing within policy and frameworks around research. So, one of my favorite quotes from my thesis participants is, it's relationships are the oil that keeps us running. And I think that's a really important note. And we know therapeutic alliance from previous research is so important. And I think, you're not going to take easily, not many people will take easily advice from an unknown person, but someone that you trust, you can come back to and feed back to safely. It's if we look at health literacy, that's a learning environment between a clinician and a patient, and we want that learning environment to be safe and, as you highlighted, Christy, more equal and less power dynamics in it. So all of those sorts of things play into a long-term ongoing relationship that enable the outcomes that we know from research. They're more than just process. It's about a learning environment for the patient within our consultation rooms, and also hopefully over virtual connections.
Well, I think that's a very good note to finish on. And I wondered if we could just pass back to, firstly, from me, thank you to everybody who's participated, and thanks to the audience. I'm going to pass back to Angela now.
Thanks, Grant. Just to reiterate to everybody online and also who attended today, our sincere thanks to our speakers for your terrific presentations. We learned about telehealth from many different perspectives, and I think there were lots of insights that would be really useful. To let everybody know, we'll circulate a recording of today's webinar, and we'd welcome your ideas about future events and bringing everybody together. And we'll sign off now and hopefully see you next time. But a sincere thanks to everybody.
Thank you.
Thank you.
Bye-bye.